job is to talk about the tips and tricks for the management of supracondylar fractures by closed reduction and pinning. As we know, this is the standard treatment nowadays for displaced grade 2 and grade 3 supracondylar fractures. You can call it the gold standard treatment for these injuries. Before you start, we have to ensure thorough physical examination, particularly looking for neurovascular deficit and compartment syndromes. Always ask for good quality X-rays in true AP and lateral views, both preoperatively as well as after the surgery. Never accept poor quality X-rays because that will lead to poor execution of the surgery and often poor results. The timing of surgery is important. Never rush up to do it in the emergency, particularly if there is a lot of no neurovascular injury or swelling. If there is a lot of swelling, just put a plaster slab, but never flex it acutely because that will increase the swelling and neurovascular compromise. We prefer general anesthesia because the blocks can take away a very important component of pain after the surgery, like compartment syndrome and all. Always mark the site of surgery. OT setup is important for easy visualization of the procedure. You have your monitor on the opposite side of the table and place the child on the edge of the table. Often we secure the head of the child for counter traction. You can either have a radiolucent board or hand table, or you can use the fluoroscope as a platform. But there's a lot of radiation in this setup. For reduction, you give sustained traction in longitudinal direction, followed by medial lateral correction, and then you press the olecranon for the posterior dislocation. If there is posterior medial dislocation, you pronate the arm. If there is posterior lateral dislocation, you supinate the arm. And then you check the reduction in AP view. It's called the Jones view in flexed elbow. Then you check the lateral view and ensure that the lateral reduction is good. You ensure that the lateral humerus line is okay, the capitulum is okay, and angle between the humerus and capitulum is okay. The rotational correction is very important. As we know, the distal end of humerus is like shaped like a dumbbell, and you have to align the distal and proximal dumbbells in one line, because these imaginary lines have to be parallel and equal. For correction of rotational deformity, you flex the elbow next and rotate the distal fragment. Check the AP view in extension. After you have done the reduction, you extend the elbow and then check the AP view. You look for the olecranon fossa and the medial lateral cortex. You also can check the moment's angle and carrying angle. But never fix without a perfect reduction. Don't accept any varus valgus and rotational deformity. Little bit of translation can be accepted. Equipment is critical. Always invest in a good quality drill with power attachment, this K-wire attachment. Always use sharp and smooth K-wires. You introduce the lateral pin first and you fix the capitulum for initial stability. This pin is directed 35 degrees upwards and 10 degrees posterior because the humerus is posterior to the lateral condyle. The starting point for lateral pin is the first hard point lateral to the olecranon. Then you check the lateral view. Now you can external rotate the elbow after initial fixation. Some useful practical tips. You can use a pad underneath the elbow for easy introduction of the pins. If you don't use it, then sometimes the drill interferes. You always put your opposite finger on the opposite side to prevent injury to the ulnar nerve. Don't use a long wire outside the chuck because there's a tendency to bend. You can use a drill sleeve to prevent winding of the soft tissues and use a stop and start technique. Various pin configurations can be used. Either we can use 2 lateral pins in a divergent or parallel fashion. We can use 2 cross pins. We can use 3 lateral pins, or we can use 2 lateral and 1 medial pin. After initial fixation, you check the reduction in AP view, then insert the second pin. Sometimes you can bend the first pin to avoid interfering in the first pin. You can use different size pins to see in the lateral view that which pin is going in which direction. Some practical other tips: never cross the fracture site and never exit the pins through the fracture site. Always engage the opposite cortex and space the pins as widely as possible. Our ultimate goal is to have a stable construct, because the poor pinning can lead to a loss of fixation and reduction. When you put the medial pin, you have to ensure preventing injury to the ulnar nerve. This is best done in the extended position, because in the flex position the ulnar nerve is tense. Feel for the medial epicondyle and insert the medial pin. The medial pin is directed slightly anteriorly, because the medial epicondyle is little posterior, so that this pin will look little horizontal on the AP view. It's better to err on the anterior side rather than posterior. You can use a small stab incision on the medial epicondyle to prevent injury to the ulnar nerve. And at the last, you bend the K-wires and cut the K-wires carefully to avoid loss of reduction and fixation. Thank you very much.